Hello, thank you for choosing this lecture today. My name is Sherry Kozubal. I am a registered respiratory therapist, a registered polysomnography technologist. I have my certification in clinical sleep health, and I am a certified clinical hypnotherapist. So what I'd like to discuss today is sleep disorders common to healthcare workers. So what are the objectives we're going to look at here today? What I'd like to discuss is basically two common sleep disorders that I've identified when looking through the literature at this particular topic, discussing the factors unique to the healthcare setting because it is quite unique in several different ways, listing the effective approaches for reducing risk, looking at what normal sleep is. Most people have an idea of what it is, but there are many different ways to look at that, listing management options, and finally some study discussion. So what is normal sleep? Many factors that we look at when you think of what normal sleep is. Some people will think of quality, some people will think of timing, some people will think of duration, and some people will think of factors of all three. The fact is that the variability in what we consider normal is quite high due to biopsychophysiological factors. Now, those are factors that are specific to age, gender, cultural influences, demography, geography, that sort of thing. So basically, if you live in different parts of the world where the weather dictates that there's not a lot that you can do during the day because it's quite cold, or there's lack of sun, people have been known to basically adapt to those particular situations so that they can be as efficient as possible. And so what's happened too is that they've become a little bit specific to that general region. Also, there's things like social or cultural influences that come into play there as well. And often that is also tied to the geography as well. So what it all boils down to when you think of all these biopsychophysiological factors is they affect duration the most. So when we look at what normal sleep is, we tend to focus on duration. So this is where the American Academy of Sleep Medicine, or the AASM consensus came out with the amount of sleep necessary to support optimal health as being about 7 to 9 hours in length. So normal polysomnography. Polysomnography is the study of sleep, and this is through many different factors that we're looking at when we're studying sleep in a sleep lab. We look at that normal period of sleep, 7 to 9 hours, and it's going to have approximately 5 cycles of sleep. Now, within each cycle of sleep, we have 2 different types of sleep, non-REM and REM. So non-REM is broken down into 3 stages. It's the stage 1, stage 2, and stage 3. Each stage going progressively deeper in the depth of sleep. And the time that you spend in stage 3 is the most at the beginning of the night, and it decreases over the course of the night. And REM is the inverse of that. So basically what we end up with is most of our stage 3 sleep in the first half of the night, and most of our REM sleep in the latter half of the night. So when you're thinking about having your sleep time curtailed in one way or another, these are the effects that you're going to see on the sleep specifically. So normal polysomnography, what is normal? So stage 1, when we look at stage 1, it's basically a transitional light stage of sleep. It's not consistent sleep. Stage 1 is this transition from alpha to theta, and it goes back and forth for quite a while before we transition back into stage 2 sleep. Stage 2 is about 50% of our sleep cycle, and this sorts are all our useful memories for easy retrievable access. It's usually where most adults will find themselves in sleep for the duration of the night. Children, of course, are in more stages of stage 3 sleep, which is deep sleep, than we are. And it's stage 3, when you look at stage 3 for adults, we're only expecting about 20% of the night. And then that, of course, decreases with age and depending on the person as well. Stage 3 sleep is so, so important. It's responsible for body repair and restoration and memory and consolidation as well. So when you look at children, it's no surprise that they have more stage 3 sleep than we do because they have more growth than we do. We're using the stage 3 sleep mostly for repair and regeneration. REM sleep, finally, it's all on its own there. Basically, it's about 20 to 25% of the total sleep cycle. There's two phases of REM, phasic and what we used to call non-phasic or tonic now. And if you think of REM, if you were to catch somebody sleeping in REM, you could see them in the phasic phases of REM with their eyes moving underneath the eyelids. And these are the parts of the brain basically that are associated with learning that are activated in REM. So normal sleep architecture. So when we look at these sleep phases, these sleep phases, basically we're looking at them cycling one after the other throughout the night. So each cycle happening about 90 to 120 minutes in length, starting with awake down to N1 briefly or non-REM 1 briefly, and then down to stage 2 for a shorter period, and then stage 3 because we have this more of a concentration of stage 3 sleep in the first half of the night. And then you can see that waning off towards the end of the night and REM taking more of a center stage. So who is a healthcare worker? So this is the interesting thing that the pandemic has brought to us when we look at who is a healthcare worker. I think traditionally, when we've thought of healthcare workers, we thought of the acute care setting with doctors and nurses, but really this is such a broader group of people. And again, with COVID, we saw in the acute and chronic care settings, a lot of these places quite overwhelmed in that time period. And we also noticed that, things like the specialty and the rehab and the palliative areas were significantly curtailed in that time period. Everything was just basically put on hold in these areas because this is where we identified where people were at the most risk. There was so much going on in terms of what was required in the acute care setting that when it came to things like rehab, we were shut down to what was absolutely required. But we saw the ripple effect of this where, we didn't have workers in some of these settings, such as specialty or rehab. And this put such an incredible strain on our system and caused more difficulties for people on their path to recovery. The other thing, too, is when we look at healthcare workers is people in healthcare offices. So this was another thing that we didn't consider as much. So dentist offices, doctor's offices, people that weren't directly linked to patient care, but were involved in that care setting. There's a study that we're going to discuss a little bit later, basically on the effects on these people and how significant it was, and basically how much we are missing the impact on these people. And I think the biggest takeaway here with healthcare workers is, when they don't function optimally, it creates this ripple effect through our entire network. And it's very important to keep these people healthy. So what are the unique demands of this healthcare system? So if we look at the acute care system, like a hospital, patient care is 24 hours a day, and it's often adrenaline / cortisol filled. This is a very unique situation for an individual to work in on a regular basis. Our bodies are not designed to do this. So it takes a lot of planning and thought to support people in these systems so that they don't get burnt out, so that they are working optimally and so that they can live a life outside of their work as well. The other one is emergent patient care favors dedication to patient outcome as opposed to self-care. So, when you're working in this adrenaline system, that field system where you can see that this person is not going to make it if you're not 100% on, and you need to do whatever it takes to get them through that, you're going to not be looking at what your needs are. And then, of course, that's going to ripple out into the rest of your days and weeks to come. Fatigue is also looked at as dedication and excellence. It's a culture. We just expect doctors and nurses and ambulance attendants and first responders to be tired, and it's part of their what they do. So it doesn't mean it's normal. It just means that we see this a lot and we just expect it. We also work in a system that is inflexible to circadian rhythm resets between shifts. So especially during pandemic, when there wasn't enough people, a lot of these healthcare workers did not have the time between their expected shifts. So they would typically, if you're on a shift work, you would do 4 on, 4 off, or four on, 2 off, and then switch over to days or something, different like that. But with the lack of a staff that we had in that particular system, and not to say that that doesn't happen in other times of the year where we have influenza and other viruses that tend to overload our system more than usual, that we're not giving people the turnaround time that they need to reset. Environment is basically artificial light and a lot of chaotic activity. So this is all stimulating to the nervous system and keeps you on a wired sort of way of being. And finally, we all know this one, a bad day at work can be a loss of life, even when we do everything right. So to our best of abilities, we're doing our jobs, and sometimes it still is not enough. It's just a fact of our jobs. So sleep disorders specific to healthcare workers, basically what I found most prevalent in the literature was shift work disorder and insomnia. So shift work disorder relates to the extrinsic circadian rhythm disturbances of night and day shifts on the intrinsic biological clock. So these are people who are working night shifts, people who are working in artificial light all of the time and not getting the cues from the outside, from the sun, to help set their intrinsic body clocks appropriately so that they can have the appropriate pressures to sleep and the appropriate pressures to wake when they need them. Insomnia is outside of that biological clock piece, and basically it's hypervigilance that we see related to work demands or work-related trauma from, like I said, sometimes even your bad day at work is when you do everything right, you still are not successful in helping someone. Shift work disorder. So shift work disorder, it's an extrinsic circadian rhythm sleep-wake disorder characterized by daytime sleepiness and or insomnia for a period of 3 months, and then the presence of rotating shifts or night shift schedules. So in this case, insomnia is secondary to the shift work disorder as a result of this shift in the intrinsic circadian clock. So what we understand is that the master circadian clock in the brain is regulated by exposure of the eyes to light. So it influences so many things, not just the sleep-wake cycles. It influences hormones, body temperature rhythm, and also your eating and digestion. So you will see people with this disorder will have influences in all of these areas. So we'll see things like mood disorders and gut disorders and just issues in general with all of those things. And I think the biggest thing that the takeaway here as well is that night shift results in 1 to 4 hours less of sleep compared to day shift workers. That is so significant. if we look at the amount of hours that you need in a night, let's say the 7 to 9, that's that normal sleep, and we're cutting that back by at the minimum 1, we're missing a whole cycle of sleep, which is quite significant. That's probably the largest piece of REM if you're looking at the end of the night where someone wakes up too early. Or just in general, just having the sleep cycle disrupted so much because they're wake sleep, not getting that pressure where they need, and they're not able to cycle through those sleep stages as they're supposed to. So shift work disorder and the healthcare worker in particular. So we know that 2% of the general population meets the criteria for shift work disorder compared to 20 to 33% of healthcare workers. So why is this? It basically comes back to the unique situation of the healthcare system. We've got 24/7 artificial light. We've got the stress of caring for another human being. And then we add in the shift work on that. That all adds up and creates a much more significant circadian rhythm shift. Greater incidences are noticed in this population with insomnia, metabolic disturbances. Again, that's that master circadian clock, depression, anxiety, and higher incidences of suicide or suicidal ideation. And these, of course, are hormonal related in that master circadian clock, and generally mood disorders are the result of those shifts. The other big one here too that surprisingly not looked at a little bit more closely is how much in healthcare workers with sleep disorder that insomnia is linked to functional and cognitive impairment. So this is work-related mistakes and memory impairment. So what we know is that overnight occupational and neurophysiological impairment is more strongly correlated to insomnia than it is to sleepiness. So, if you have someone who's saying that they're tired, but I'm not going to fall asleep. Well, if they're experiencing insomnia, we know they're having neurophysiological impairment. So that means that their risk factors for work-related mistakes are going to be significant. So we need to look at that in terms of helping people and supporting them in being their best while they're on shift, so that they can be healthy and that they can help people in the most optimal way. So how do we manage shift work disorder? So in general, the first order of addressing any sleep difficulties or extreme fatigue is to address the current sleep hygiene practices. And we also need to bring attention to timing, quality, and quantity of sleep. So I will never forget one of my first experiences in the sleep lab with a patient climbing into bed with a chocolate bar in their hand. And I was blown away that they had no idea that this was something that you shouldn't do. It was just something that, quote unquote, they've always done. And so it was normal to them, but they didn't know any better. So when we can look at somebody's all of what they do, their rhythm, their quality, their timing of their sleep, and things like exercise, their social challenges, their physical activity. Look at the whole picture and just understand a little bit more where they're starting from. We can give them a little bit more effectiveness of any technique that they try if we start them off from optimal diet, optimal exercise, and optimal idea about what good sleep is supposed to be. So the ASM has put forth several recommendations for healthcare workers, and this is because a lot of these healthcare workers, they start to see things that they do with their sleep as normal as well, just to kind of get through. So using things like coffee at different times when maybe, they could be optimizing that a little bit better, or seeing sleep as normal when it actually isn't, and just giving them an idea of what is normal and what is not. And they're suggesting several activities that alleviate stress load as well, prior to bed. And this is a huge one. This is basically goes back to helping somebody shift down from their high response mode of working down into the shutting down mode of sleep, and allowing their bodies to rest and their minds to rest as well. That is the challenge, is to get the two to do that together. We also look at, the activities that optimize our hormonal pressure to sleep. So this has got a lot to do with the light exposure, and what you're eating is another one too. So optimizing the way your body is working. And then, of course, minimizing extrinsic stressors or stimuli around you. Again, that's got a lot to do with light or the social factors. So, any other big one that they look at with this one is that light exposure. And, this is predominant through most of the shift work disorder management. And what it really has to do with is when we don't have access to that external biological reset of the sun, that we can manage light when we're aware of what we need for wake and sleep, and timing that as best as possible. So what's the role of diet and exercise? So basically, I touched on this a little bit already, but when we can control factors like digestion and our stress and our activity level, then we can optimize our hormones and metabolism to set us up for giving us the state of alertness that we're requiring when we want it. So it's just a matter of actually being aware of what your body needs and what state of alertness are you looking for. And so making choices according to that. So calm activity, low light, positive emotions, it's going to stimulate serotonin and dopamine release, and it's going to allow you to slip into that beautiful alpha ECG rhythm, and which is that borderline into sleep. Alternatively, if you're wanting to be on, let's say you're tired on a shift or something like that, bright light, strenuous activity, things like that is going to increase cortisol levels, and it's going to give you that natural fight-flight response and increase that body alertness, and that would put you in a high beta ECG rhythm or EEG rhythm. The American Academy of Sleep Medicine basically suggests that, in order to do this mental reset is to give yourself a 30 to 60-minute buffer before you head to bed. So most healthcare workers are coming out of a situation where, even if they're not running around in an emergency room, they might be dealing with ideas from like a medical doctor's office of someone who's come in a palliative situation, or someone who has lost a loved one, and that can sit on one's mind. So what the ASM suggests is that we do a mental switch over from the work brain to the sleep brain, or if you want to look at another way, the sympathetic to the parasympathetic mode. And they suggest a few different ideas of how to do this. But, basically what we see with healthcare workers is they don't often do this. And they don't do this shift for several different reasons. One, sometimes they simply don't have the time. They have work and home life demands, and then when they finally do get the chance to lay down, they're so tired they don't do that shift, that conscious shift from beta to alpha and into theta. So beta being that high beta being that fight flight response, low beta being that conversational response, alpha being that that transition between wake and sleep, and then finally into theta, which is sleep. So they don't consciously do that shift simply because they're either too tired or they don't want to bring awareness to the quietness too, because sometimes when we finally give ourselves time to process, it can feel overwhelming, especially from what we've been exposed to. And the reality is that, most of these workers just fall asleep much sooner than 30 to 60 minutes when using our suggested techniques. So it doesn't have to be this time where you're going to be forced to consider the rest of your day. It really is just about bringing awareness to the ability that you have to shut down into a state of rest. So breaking old patterns. So basically breaking old patterns, this is a hypnotherapy idea as well. So a lot of times, we get learned behavior through negative experiences, and this can create things like cyclical insomnia. So what the AASM suggests is that we reassociate sleep with positive by waiting until we're tired to go to bed, and then utilizing the bed for sleep and sex only. So if we add in these other stimulating wake activities like TV or any sort of electronic device or high tense exercise or caffeine or some sort of stimulant, then our bodies have these cues to be awake. And then, of course, we're going to lay there in this bed that we understand is supposed to be for rest and sleep, but we've cued it up to be awake. So then we start associating the bed in a negative way because, this is something that we are not successful in achieving with sleep because we've set ourselves up in a negative way. So what the ASM suggests is that if you wait until you're tired, then you can reassociate that bed in a positive way because, setting yourself up for success, making sure that you've done everything you can to cue your body to sleep, making sure you're tired, you climb into bed, before you know it, you're asleep. And then you start setting up a pattern of positive experiences. And then, of course, success and feeling like the bed is associated with success of sleep and a time of rest. So these are the behavioral foundations of cognitive behavioral therapy for insomnia, or CBT-I, and brief behavioral treatment for insomnia, which is BBTI. So how do we make this mental switch? I talked a little bit about this. So soft lighting, of course, this has got a lot to do with circadian rhythms and cueing the body that the sun is about to go down. And it's just this natural sort of expectation that we've developed from the time that we were little, that when lights start to dim, this means the sun is going to bed, and then perhaps we should be as well. Reading is getting you from that high beta fight-flight state into a low beta state. So it's a natural sort of gear down. Think of it as shifting down in speed from a higher gear to a lower gear. Taking a bath is just a natural somatic cue so that your body feels this sort of naturalness of being calmed and soothed. Meditation or apps on guided meditation. So this is, again, getting you into that alpha state, which is that transition from wake to sleep. The difference between going into meditation or going into sleep, of course, is intention. Listening to calming music. This is a frequency thing. So what you're looking at is, it's like a tuning fork, basically. You're setting up your brain to tune into rhythms that are more set to a parasympathetic state. And of course, audiobooks are about helping you dissociate from the rest of the day and just helping you shut down. Gentle stretching has a lot to do, again, with releasing tension in the body. Again, it's a cue, a somatic cue for you to release and let go. And that's also a natural thing that we see with sleep. So this is a very interesting paper through the Journal of Clinical Sleep Medicine by Dr. Gupta. And basically what he was considering with shift work disorder is that it's such a complex disorder. It's got so many obstacles and so many pieces to it. When you look at the healthcare worker, it is really difficult to understand when to apply light for the healthcare worker, for cueing them to wake or sleep during their shifts. So what he looked at is doing it from a preventative way. So he was looking at this type O resetting, which is to set up a specific cueing of light exposure a few days prior to shift work set that's going to start, and to basically cue the body to slowly to get onto the shift that is expected that may not necessarily be tied to the external, like the sun. So really interesting topic he had here. I love that he brought into to light to hear that there's a real lacking of expertise in identifying shift work disorder. Again, it's the cultural expectations. So managing fatigue, better sleep. So when we've done everything we can to optimize our sleep patterns and our timing and our light exposure, we're looking at how do we manage the fatigue. So you can use things like calming medications such as hypnotics and sedatives to help improve that total sleep time. So it does give more of a pressure to sleep while you're in bed, so that, if you were to wake during your sleep and you've had, just enough sleep to get a little bit of rest, and then those circling thoughts start up again, hypnotics and sedatives can reduce that middle insomnia to increase your total sleep time. The drawback to them, of course, is that hangover effect that can happen with these. Managing light exposure, again, we're going back to that. So brightness and the timing, of course, resets your internal master clock or stimulates melatonin production, depending on what you're looking for there. So if you're thinking of working a shift where you're feeling quite tired and maybe you don't have time to sleep, it's about having your workspace in brighter light so that it's stimulating your body to understand that this is a time to be awake. You'll notice that a lot of people on shifts, if the work is a quieter sort of work, will have the lights dimmed. You should never do that when you're working nights. You want the body to be cued to be awake. And then as you're gearing down towards the end of your shift, go ahead and start dimming the lights to allow the body to understand that, yeah, okay, we're going to be going to bed pretty soon, and no different from what a setting sun would be like. Melatonin timing and dosage are key to desired effectiveness. So we need to understand when you give the melatonin to allow it to do its work the best, and exactly how much you should be taking. Higher doses have a sedative effect, and lower doses are about resetting internal clocks. And a lot of people don't quite understand melatonin. What they do is that, probably 15 minutes before they go to bed, they'll take some, and if it's not working, they'll take more. But it really has a lot to do with when you're planning on going to sleep and how much you're taking. And this is something that a board certified sleep physician would be more knowledgeable on directing people with. Managing fatigue stimulants. So this is another one with managing fatigue that we mostly see. It's chemical mostly, right? So timing, it's everything. Like I said before, mostly with things like caffeine. Caffeine is a 12-hour half-life. If you take it too late in your shift, it's going to be pressuring you to stay awake, or it's going to give you lighter sleep. If it is, again, you can get used to the effects of caffeine. So, and things like coffee, so if you take the lower amounts in the first half of your shift, you're going to have more long-term success using this, because the body's not going to adapt to it, and really only using it when you feel like you need it. Modafinil is another one that's indicated when all else is optimized, but it can have some gut effects on some people. We see this a lot with narcolepsy. People use modafinil, and they'll notice that the gut effects can be quite substantial sometimes. So, but it is a very effective drug when used. Exercise is another one. It elicits hormones in the sympathetic nervous system. So again, on a shift where you're feeling super tired, if everything else is optimized and you need to wake up, go for a brisk walk outside, go for do some jumping jacks, do whatever you need to do to elicit more of like a sympathetic response. And again, this can be helpful with relieving the stress of that shift as well. So it's going to be using up that that fight flight response that isn't able to be expressed perhaps in the shift. Maybe you can't express in emotions, but if you leave and go do some sit-ups or push-ups or jumping jacks or going for a brisk walk, you can vent some of these emotion fueled stressors in that time period. It's quite helpful. The last one is eye movement. Eye movement is really cool. So basically what we're doing is we're stimulating beta activity in the brain. And this is really, really useful for people who are driving long distances. They always say when you're driving to keep your eyes moving on the road. And the reason they're saying that is because when you keep your eye fixed on one thing, like just the road in front of you, your peripheral vision goes away. And the reason why that happens is because you're shifting into alpha state. And that's basically meditative state, and it shifts into hypnosis if you do it long enough. So your reaction time to things is going to be reduced in these states. And it's not helpful if a deer were to run out in front of you, let's say. The other thing too with this, the beta activity movement. So when you're sitting there at your desk and you're finding it difficult to kind of stay awake or do what you need to do, stand at your computer, honestly, just moving your eyes around your room, doing what you need to do to keep them moving, just as if when you're in a car trying to stay awake and moving your eyes around the road to stay alert. No different in your workspace. All right, insomnia disorder. So in the International Classification of Sleep Disorders, it's defined as a complaint of trouble initiating or maintaining sleep. And this is associated with daytime consequences that are not attributable to environmental circumstances or inadequate opportunity to sleep. So that's those environmental circumstances are what we're talking about with the circadian rhythm shift disorders, and the inadequate opportunity to sleep is another sleep disorder. It's basically where people are depriving themselves of adequate time to sleep in bed. So that's not what we consider insomnia. Insomnia is acute or it's chronic. And this is where, despite the fact that you're spending the time in bed, you're not able to sleep. Chronic basically persists for at least 3 months at a frequency of at least 3 times per week. And acute is the same, except that it persists for less than 3 months. We see this more often in advanced age women and lower socioeconomic status. And also people with medical or psychiatric illness are also have higher risk factors for acute or chronic models. So the prevalence of chronic insomnias in the general population is 5 to 15%. Now this is a guess because a lot of people don't talk about their sleep. It's again part of our culture too, where we don't want to be looked at as incapable or broken or not doing well. And depending on where you come from or what you do, that can change quite significantly. So if you looked at somebody in a safety critical occupation, they're not going to talk about how much they're not sleeping, because then someone's going to start looking at how well they're doing their job and, looking at whether they should be changing what they do. So among healthcare workers, of course, when you look at that idea, it's estimated to be much, much higher due to the multiple stressors. But again, we don't know, because this is a culture that expects to not sleep, expects to be tired. And it's unfortunately considered normal, which it is not. It can exist, it is a component of the shift work disorder, but it also can exist independently. When we see healthcare workers, so like I was talking about, people who work in medical offices or dental offices and are not working night shifts. It is a definite risk factor for mood disorders such as depression, poor quality of life, and an increased risk of suicide. And this goes back to not being able to cycle through those sleep stages appropriately or in the right amounts, so the brain doesn't get its quote unquote defrag of the hard drive. So when it doesn't get that, it can't sort memories and things that it learned in the environment for quick, easy, retrievable data, and it can't clear out the garbage. There's a lot of studies on the metabolic dump, or the protein buildup that can happen in the brain when we don't get enough sleep. We also see some studies with Alzheimer's where there is the protein buildup in the brain, and we see that quite often when people are deprived of REM. We'll see buildup of the same proteins in the brain. Very interesting study, this one here. This was a study that was done before and during COVID-19. So it was quite lucky, actually. Obviously, they did not plan the studies, but they started the study just before COVID-19 hit. And what they were looking at is the tertiary care centers. And, a portion of these people were not in direct contact with patients. And the most surprising finding that they had was that the less time spent in direct patient care was associated with more cases of the acute insomnia disorder. And, of course, this was a complete surprise. They did not see this one coming. Their hypothesis is that we just don't understand the stress of working from home, especially during a situation like COVID-19. So the other thing that stood out with this study was the prevalence of insomnia prior to COVID. 44.5% of the people had insomnia, either acute or chronic. And then during COVID, it was 64%. So significant increase during, but prior to 44.5%. How is that acceptable when insomnia is associated with a higher risk for mood disorders and the potential risk for suicidal ideation? This is not a good thing. It implies, like the author said, a need for awareness on the part of the healthcare system leaders, both in healthcare settings and in home. So we need to look a little bit more about how healthcare workers are being impacted. So this is a clinical practice guideline that's put out by the American Academy of Sleep Medicine. This was published in the Journal of Clinical Sleep Medicine. Basically, the AASM recommends that clinicians use CBT-I as the primary treatment for insomnia. And in the event that that is not available, they suggest that you use the shorter version, which is a brief behavioral therapy for insomnias. And then, of course, it goes below that, which is either using the single components of those therapies, which would be stimulus control, sleep restriction, and relaxation therapy. And then, of course, sleep hygiene. But of course, these are conditional based on the fact that it's at the healthcare professional's discretion and often in use with other tools and therapies. So insomnia interventions, like I said, psychological and behavioral interventions are primary interventions for all ages and chronic hypnotic users, because most people with insomnia will be coming to these healthcare individuals with chronic hypnotic use already in place. CBT-I, of course, is the first recommended, then the behavioral therapy. And the behavioral therapy, stimulus control, relaxation therapy, and education regarding behaviors that influence sleep, those are the major components of the behavioral piece. So relaxation therapy, this I thought was very interesting. So the American Academy of Sleep Medicine, what they're suggesting for relaxation therapy is two different things. So depending on your suggestibility, it's going to be either a mind-based or a body-based. So mind-based is going to be cognitive arousal reduction. So the guided imagery training and meditation. So that's their primary modes of reducing the amount of cognitive arousal in the brain. And of course, both of these techniques bring you from a high beta down into an alpha state. And again, it's just teaching people to consciously shift from a state of consciousness, of a high state of consciousness, to a lower state of consciousness. And when people feel like they can actively do that in a safe way, then they're able to do that quite safely with sleep as well. Somatic tension reduction. This is the body awareness piece. And so people who relate to the world in quite a literal way. So if someone says, well, this is red and this is green, then they understand, well, that's red and that's green. So they're very literal. They won't read into anything. So people that see the world in this sort of way do really great with this sort of therapy. So abdominal breathing, progressive muscle relaxation, and autogenic training. So depending on your suggestibility, one method's going to be more effective than the other, but they likely use both of these techniques in the CBT-I. Sleep restriction therapy is a popular one used with insomnia. And basically what we're trying to do is consolidate the sleep by enhancing the sleep drive. So what we do is we get somebody to have a sleep diary first, and then what we determine is the actual time slept. They'll write down that the time that they had in bed was maybe 10 hours. And when they add up all the times that they felt that they did sleep, it maybe add up to 4 to 6 hours. So we ask them to restrict their time down to the time that they felt that they only sleep. And so they will do that to start. So they set a timer to go to bed and then when to wake up. And they will be quite tired at the beginning of this. So a lot of patients do not like this because they have an increase in hypersomnolence at the beginning of this type of therapy. But as we start to increase the amount of time in bed up until where they're satisfied with the amount of sleep and feeling rested in the morning, they will notice quite a difference in their sleep, and the sleep will be consolidated as well. We don't use these for people with mood disorders and seizures. Now, of course, it's interesting because a lot of people with mood disorders are going to have sleep issues. So unfortunately, this is something that can't be used for those people. So off the table. Really interesting that this comes up as a therapy when a good portion of mood disorders have insomnia. So yeah, I thought that was interesting. Stimulus control instruction. So stimulus control is basically reassociation. So we're going back to that learned behavior thing that I was speaking about earlier. So going to bed only when you're sleepy, making sure that you're optimizing all the things you need to do to allow your body to get those proper cues to feel tired. And then getting out of bed when you're not able to sleep, typically it's about 20 minutes that we expect you to try to get back to sleep. And then if you're not successful getting out of bed at that time, and then going to do something nice and quiet until you're ready to go back to sleep again, feeling like you're tired enough and going back. And so we're using the bed only for sleep and sex. So reassociating it with positive experiences only. And then waking up at the same time every morning, that goes back to the circadian rhythm resetting and refraining from that daytime napping. That's again, keeps you from being shifted in that circadian rhythm disturbance. Pharmacotherapy, we often see pharmacotherapy used in CBT-I as well. It boosts the effectiveness of it because during the course of CBT-I treatment, we don't often see an increase in sleep time that happens. It's actually much later. So pairing pharmacotherapy with CBT-I to begin can help that the patient feel like they're achieving some success with it. Of course, like I mentioned, a lot of people come into therapy with chronic hypnotic use in place, but perhaps that when they're talking with a sleep professional, that they're able to get a hypnotic that is going to be more effective during that time period. Of course, the one that the sleep doctor will look at will be dependent on comorbidities, availability in that particular region or country, cost, patient preference. Maybe the patient is not too keen on having something that's going to knock them right out, or maybe they do want something like that. And then, of course, treatment goal as well. So reducing the stress, bringing on the sleep. So the more you practice a calm state of mind, the stronger your mindset becomes. So stronger mindsets, we know, will increase your resiliency and lower your stress, because when you have a strong state of mind, so understanding that you're able to influence the level of arousal that the brain has at any particular time by what you're doing. So what you're eating, what your activities are, what your environment is like, all of that. When you can optimize all of that and have your body working for you as a tool that you're using to create an experience, it becomes a strong mindset. And that gives you increased resiliency to anything that happens in your environment. And of course, when you're more resilient, you don't have stress. So really, really cool sort of ripple effect when you realize what you're able to do with what you have. Interesting thing that on the ASM website, they have apps that you can use as well. They recommend Calm. Most people know this one. It's mostly audio, a lot of feel-good vibes, meditations, things like that. All of those helping people understand that they can shift their consciousness from a high arousal to low, and achieving what they want for an experience. Netflix, really interesting. It uses visual and audible, and it's all about monotony. It's like boring, like watching a fireplace maybe, or a fan blowing or something. Like it's all about repetitive monotony. And anytime there's monotonous things going on, that again shifts the brain into alpha state. It's just it's a popular hypnosis trick to do. So yeah, those are two really interesting apps to check out if you're looking to learn a little bit more or practice about shifting into lower states of consciousness. So why is alpha state so important? So we consider this a lower state of consciousness because it's not that you're not aware in alpha state, but it is a bridge from the conscious to the unconscious. So typically when we're awake, we're performing daily activities, depending on how significant the activity is. If it's a very significant activity, then it would be high beta. If it's like a conversation with somebody, it's going to be low beta. And then when we close our eyes and we take that little breath in and out, we're shifting into alpha. So it's a nice calm way of being. It's also what we see with meditation, later states of meditation. And we usually have to pass through alpha. I mean, we do have to pass through alpha. It depends on how consciously you're doing it, with for how long that you're going to stay in it. So activity, things like exercise, electronic usage, problem solving, it delays our sleep onset until the brain overrides us and it crashes into theta. So typically, if you're doing everything right, you're closing your eyes, you're not exposing yourself to activities in your bedroom that are trying to keep you awake, you'll probably go into alpha, for a fair amount of time, probably anywhere between 5 and 20 minutes, which is a nice calm state. And then you'll shift into theta. When we are trying to stay awake, but we're very tired, or we are in that high beta state from our jobs, and we've got lots of problem solving going on in our heads. But again, we're very tired, and we finally just close our eyes, and the pressure to sleep is enough to push us through alpha briefly and straight into theta. Now, this is fine and everything. However, when you sleep enough, maybe you get one sleep cycle, it's an 90 to 120 minutes, and then you shift up into that lighter sleep stage again. If you're awake enough there and you've gotten enough sleep and you don't have that pressure anymore, well, that pressure was your ticket into sleep. Now you don't have that pressure. So understanding how to shift back into alpha is so, so important. This is where middle insomnia comes from. People wake during the night and start problem solving because they're not tired enough to force into sleep. So a person that's going to train using meditation, hypnosis, calming apps, or doing quiet activities like reading or listening to music are really aware of how to initiate alpha and practiced at staying in alpha, and they feel safe and calm in that state as well. And they'll be able to initiate that during sleep and during the night. So say they get woken up by something, they know how to get back into alpha state because they've already practiced. So that's why it is so important to have. So expected outcomes of intervention. So basically when we have, excessive sleepiness, alertness, this is all about how much sleep did you get? How did you structure your time? How did you structure your work? All of that stuff. Total sleep time, of course, if you don't have enough, you're not going to get enough of those sleep cycles, and you're not going to get that defrag of the hard drive. Sleep quality, that has everything to do with getting those right amounts of each sleep stage, and not being disturbed and disrupted in that natural rhythm of those cycles throughout the night. Circadian alignment, that has a lot to do with that, getting that internal circadian clock optimized, because it's tied to the outside world and optimally your work time as well. Your quality of life will also be drastically improved now because the internal circadian clock is optimal and your hormones and everything are also optimized. Your mental health is going to be optimized because your hormones are optimized, and you're able to manage your social and your work life accordingly. Cognitive performance, work performance, this all has to do with, again, that defrag of the hard drive. So if you're sorting all of those memories and your adaptations to the environment for quick, easy, retrievable places to find, you're going to be able to do your job better every day. And accident risk, of course, that ties to that as well. Sleep efficiency is going to be optimized because we're not going to have those wake times for as long during the night, because you're going to be able to shift your way back into sleep quickly with that learned alpha. And the GI symptoms have a lot to do with that hormonal balance. So in summary, as I mentioned earlier, awareness and sensitivity needs to be elevated to the importance of sleep on the quality of work, our overall health, and our safety, so that the healthcare worker can confidently provide compassionate support. Now, we don't look at this close enough, and looking at some of those studies I mentioned earlier, the impacts that we weren't aware of. And this is one of the highlights that COVID brought out, that we need to be looking at this because it was not recognized earlier. We also need to focus on supporting the healthcare worker as a whole. This is one of the beauties of how the American Academy of Sleep Medicine recognizes we need to address people with the whole person. So diet, exercise, and what they're doing with their sleep. And then supporting, this supports that complexity of the shift work disorder a little bit better. Again, we would hopefully come at it from a preventative standpoint, and decrease all these risk factors that we have that are associated with insomnia. And we also need to ask care centers to consider their ability to allow for this shift between shifts for our healthcare workers, offering perhaps decompression techniques. We see this with first responders, but again, it doesn't seem to be as structured or as required as it should be. And this is in relation to work stress and trauma. offering sleep education, the more you know, the more you can know to do something about it, and hiring the adequate staff so that that culture of expecting to help others at the expense of yourself can lessen a little bit. So that's my presentation. These are my references. If you have any questions or concerns with it, please feel free to reach out to me at any time. You can find my site at breathehypnotherapy.ca, and you could email me as well, Sherry at breathehypnotherapy.ca. Thank you so much for attending.